Hi everyone, today we'll be going through a series of miscellaneous approaches. We'll be covering fever, an approach to itch, periorbital swelling, some differentials for the PACES exam for rashes, and ulcers. So beginning with fever, I think an important starting point is to identify certain key important features that would significantly shape the differentials for fever. So this would include travel as well as immunosuppression that may occur in the context of a patient with background autoimmune disease or transplant who is taking autoimmune medication. And the second big group for autoimmune, or rather for immunosuppression, would be patients with retroviral disease. So these may be patients with known or not known retroviral disease, and hence looking for risk factors would be important. In the context of immunosuppression, it is important to note that common infections such as community-acquired pneumonias are still the commonest infections that we see, but it would be important to consider opportunistic infections as well as hematological malignancies, especially in transplant patients. In patients with fever with associated lymphadenopathy, infections such as HIV and TB should be considered. Hematological malignancies like lymphoma, autoimmune connective tissue diseases like sarcoidosis, systemic lupus erythematosus should be considered, and viral infections like CMV, EBV as well. In terms of etiologies to fever, most commonly, of course, would be infections, which can then be broken down to bacterial, viral, fungal, or parasitic infections. Also importantly would be that of malignancy-related fevers. So commonly would be hematological malignancies with associated B symptoms. There can be associated night sweats, other constitutional symptoms, or sometimes even in visceral organ tumors, there can be associated tumor fever. Connective tissue disorders, autoimmune disorders, many of them can cause a low-grade fever. So conditions like lupus, RA, the seronegative spondyloarthropathies, sarcoidosis, these can all cause fevers as well. Hyperthyroidism that can be due to subacute thyroiditis can actually cause a fever that goes on for a duration or a period of time. In patients with let's say Graves' disease who come in with sudden high fevers, it's important to consider thyroid storm, especially if there are other associated symptoms. Drug fever and central fever are normally diagnoses of exclusion, but may be considered in the appropriate context. So just to consider a few specific things about infection. So in patients with prolonged fever, I think important infection to think about would be that of tuberculosis, infective endocarditis, abscesses that may be occult, HIV with associated opportunistic infections, as well as malaria. The next list basically goes through the different systems where infections may happen and the associated localizing symptoms. And for travel history, it's important to ask about specific exposure such as soil and water exposure, animal exposure, food exposure, vaccinations, and appropriate malaria prophylaxis prior to travel to malaria endemic countries. So just a few infections to point out and some of their associated features. So for malaria, oftentimes the pattern of fever may follow a certain interval. And in severe malaria, there can be associated CNS involvement, hemolytic anemia, and liver dysfunction. The diagnostic modalities and tools are stated, and treatment would be based on the resistance epidemiology based on travel history. So for typhoid, of note, typhoid infection is one that affects the gastrointestinal tract. But interestingly, diarrhea is not not always present. In fact, sometimes in adult patients, we may see constipation more commonly. There often is relative bradycardia as well as a classic rash that's described as rose spots, and that can be associated hepatosplenomegaly. For leptospirosis, the common risk factor is that of freshwater swimming exposure. Commonly, patients may get a conjunctival suffusion and redness, and in a fulminant form of Wills disease, there can be hepatic and renal involvement. In terms of biochemically wise, there can be associated cytopenias, hyponatremia, transaminitis, and renal impairments. And treatment is usually with either doxycycline or azithromycin. Rickettsia, the murine typhus that we see in Singapore usually comes from red exposure. Symptoms can be fairly non-specific, and labs-wise, once again, they can be associated thrombocytopenia, transaminitis, and cell count can be fairly variable. And once again, treatment is usually with doxy. A sexual history is also important to, number one, to evaluate for underlying risk for possible retroviral disease or certain sexually transmitted infections. And other risk factors would include things like transfusions, tattoos, IVDAs that may predispose to bloodborne infections and certain infections like infective endocarditis as well. So next we talk about itch. So the way I approach itch is firstly ascertain whether or not there's an associated rash. If there's a rash, whether it's localized or whether it's generalized rash. So if there's a rash, then you are more likely to think that there could be a primary dermatological problem or something systemic, like let's say an allergic reaction. In terms of systemic diseases that are not accompanied by a rash, I think there are a few important conditions to think of. So cholestasis, so primary biliary cirrhosis, can present with an itch. End-stage renal failure with uremia is also a cause of itch. Polycythemia rubra vera can cause itch as well, and some systemic disorders like mastocytosis and hypothyroidism. Of note, certain drugs, like especially in its withdrawal context, like opioid and alcohol withdrawal, can cause severe itch and can be psychogenic as well. So I think for purposes of the PACES exam, conditions like cholestasis, polycythemia, and the hypothyroidism conditions would be the important conditions to take note of. So we next talk about eye swelling. So eye swelling is one of those approaches that we don't see that commonly in real life, but in the PACES exam, it will be something that features. I don't really have a very good approach to this symptom, but the way I think about it is, firstly, whether it's something a bit more local. So local could be something pressure related, like in thyroid eye disease, where there is excessive proliferation of the retroorbital tissues, causing there to be a perceived swelling, SBCO, as well as any form of retroorbital tumor that would normally be more unilateral. Or could it be something local, also like a rash, like dermatomyositis, when there's ongoing inflammation? This can be perceived as some degree of eye swelling. Then we look at the systemic causes. So anasarca, if there is swelling that is associated with the rest of the body, like pedal edema, one may think of a nephrotic syndrome or other low albumin states. And if it is truly a angioedema kind of picture, then looking at whether it's histamine-mediated or bradykinin-mediated may be helpful. So in histamine-mediated disorders like allergy, anaphylaxis, or NSAID use, usually there is some response to antihistamines. But in the bradykinin-mediated disorders like ACE inhibitor or ARB use, or in hereditary angioedema where there's deficiencies or inadequacies of certain factors, these conditions may not be responsive to antihistamines. Hereditary angioedema, oftentimes will be associated family history. There may be accompanying systemic symptoms like gut symptoms. So there may be, because the edema can affect the gastrointestinal tract too, so there may be accompanying symptoms of abdominal pain as well. So next we talk about rashes. So I think it would not be possible to come up with a systemic or comprehensive approach to rash in this session. But I think what I'd like to do is to point out certain types of dermatological manifestations that may feature in the PACES exam. So the first would be nodular facial lesions. There are a few conditions I think of, which include number one, lupus perennial that can happen in sarcoidosis, adenoma sebaceum that occurs in tuberous sclerosis, acne that can be a manifestation of conditions like Cushing's, PCOS, as well as discoid lupus. In terms of bullous and vesicular rashes, for vesicular rashes, commonly we think of the herpetiform viruses, so such as herpes simplex, varicella zoster infections. And for the bullous lesions, besides bullous, pemphigoid, and pemphigus, certain infections like bacterial infections can cause associated bullae. There can be paraneoplastic pemphigus, and some rarer conditions like cutaneous porphyria can also cause bullous lesions as well. So not importantly, not to forget SJS and TENS. Yep, so this would be the common causes to think of in terms of bullous and vesicular lesions. Next would be about livedo reticularis, that it's a lacy appearance of usually the limbs, the extremities, and this is often induced by some factor that causes impairment to circulation of sorts. So this could be due to a sort of a hyperviscosity state, like in hematological malignancies, cryoglobulinemia, like in hepatitis C, or a vasculitic problem in SLE, vasculitis, antiphospholipid syndrome also, where it's sort of a bit of a prothrombotic state, can also likewise cause livedo reticularis. So next we talk about erythema nodosum and pyoderma gangrenosum. So these can appear in station 5, and hence it's important to know the causes of these two disorders. So erythema nodosum usually causes nodular lesions over the shins that can sometimes be painful, can be due to certain infections like TB, strep, mycoplasma, inflammatory disorders like IBD, Behçet's, and sarcoidosis, malignancies, hematological and non-hematological malignancies, as well as conditions like OCPUs and rarely pregnancy as well. Pyoderma gangrenosum is typically associated with IBD, where ulcerative colitis is more strongly associated than Crohn's with pyoderma gangrenosum. Other conditions like RA as well as hematological malignancies can cause pyoderma gangrenosum too. In a patient who, let's say, complains with darkening of the skin, for the purposes of PACES, I think the two important conditions to think of would be Addison's disease as well as hemochromatosis and rarely amiodarone, which typically causes a slate gray appearance. And hypopigmentation can occur due to vitiligo, Ashleigh macules and tuberous sclerosis, leprosy, sarcoidosis, and tinea versicolor. So finally, we talk about ulcers. Ulcers are most commonly due to aphthous ulcers that can happen to any patient without an underlying disorder, but it's important to then look for other secondary causes. So infective causes, importantly, would be some of the STIs like syphilis, herpes, viral infections like hand, foot, mouth disease, and herpangina, and HIV can cause oral ulcers, sometimes accompanying oral thrush too. Inflammatory disorders, importantly, would be to think of SLE, Behçet's, as well as IBD. Neoplastic disorders and SCC of the tongue can begin as an ulcer. So it's important to look for red flags such as bleeding, increase in the size of the ulcer, as well as risk factors. Metabolic deficiencies like folate deficiency can cause mouth ulcers, and B12 deficiency can cause glossitis. And certain drugs, so inhaled corticosteroid typically can cause oral thrush, SJS, TENS, if it affects the oral mucosa, can be seen as erosions as well as occasionally ulceration. Of note, methotrexate and thionamides such as carbimazole and propylthiouracil can cause ulcers, especially for the thionamides in the context of an agranulocytosis picture. Yep, so we've come to the end of this series of approaches. Hope you found them useful.